All right. Hello, everyone. Thank you for joining us today. My name is Jen Braun, and I direct the AHA Team Training Program. Welcome to today's webinars, the emergence of telehealth during the pandemic. We're extremely honored to have Florida International University sponsor and lead the presentation and discussion today. Before we get started, just a few rules of engagement to highlight. Many of you are probably familiar with Zoom at this point, but a few reminders. You can access audio by listening in through your computer speakers or through your phone. If you're having issues, you should be able to access the toolbar at the bottom of your screen to switch to either phone audio or computer audio. So please note that you're in a listen-only mode during the webinar. This webinar is being recorded and will be made available on our website within the next 24 to 48 hours. And throughout the webinar, if you have any questions for our speakers, please enter them in the Q&A pod, which you can find at the bottom of your screen on that Zoom toolbar. And so at the end, I'll do a moderated Q&A session at the end with our panelists. Technical questions or comments in general, feel free to use the chat pod. And please note that all participants on the webinar can view the chat pod. So we urge you to just chat in logistical or technical questions along with any reflections that you might have throughout the presentation and discussion that you hear from our panelists. Finally, after our webinar is over today, we'll have an evaluation that will automatically pop up on your browser. We really value your feedback, so please take a moment to complete that at the end of the presentation today. So enough of me. I'd like to turn over the webinar to our first speaker, Dr. Saad Edisham. Saad, over to you.
Thank you. Good afternoon, everybody. And I saw a couple type in the chat. Good afternoon from Georgia, Fort Worth. I have a lot of family in Dallas, Fort Smith, Arkansas. I work for a company that was down there. So nice to have you all on the call today. I want to introduce the speakers and the panelists. We all work as adjunct faculty professors in the Nicole Werdheim College of Nursing and Health Sciences at Florida International University. I'm excited to introduce Nancy Humbert, who's also an advanced practice registered nurse. She's currently adjunct professor at Florida International University, teaching in the Masters of Health Services Administration. In addition to teaching for the past 4 years, Nancy has served for over 20 years at executive level positions in public health and hospital administration from 1990s through 2007. Nancy served in the Miami-Dade and Florida communities first in various and expanded leadership roles at the local level and then at Florida's Deputy Secretary for Health between 2004 and 2007, with specific oversight for public health, nursing, emergency preparedness, trauma services, and more. In 2007, Nancy joined Nicholas Children's Hospital as the VP and served there until 2020 in expanded roles, including Executive Vice President over Emergency Services. She was instrumental in developing and growing the Telehealth International Health and Outpatient Network at Nicholas Children's Hospital. Nancy has enjoyed a vibrant career with a focus on pediatrics and public health and has been a great collaborator and contributor for children and families in North Florida. Chris Kiar is a certified healthcare compliance professional who currently serves as Director of Compliance at Jackson Health System in Miami, Florida. Christopher received his Baccalaureate of Science in Health Information Management and also his Juris Doctorate and Master's in Business Administration from Florida International University. Chris also serves in the Healthcare Services Department at FIU as a professor teaching courses in finance, human resources, and legal aspects of healthcare for both undergraduate and graduate programs. In his capacity at Jackson Health System, Christopher handles complex compliance, privacy, and ethical issues that arise as he's the Chief Compliance Officer for both Jackson North Medical Center and Lynn Rehabilitation Hospital. As a Cuban American who grew up in Miami, Christopher is very passionate about serving and giving back to the community. Christopher has logged hundreds of hours volunteering at the Boys and Girls Club of Miami, the Children's Trust of Miami-Dade County as a national member of the American Hospital Association Ashram Board of Ethics Committee. Lastly, a little bit about myself. I'm currently a market president for Novant Health in Charlotte Market. I'm also the president of the Presbyterian Medical Center. Like Nancy and Christopher, I teach as adjunct faculty in the Master's in Health Administration Services program at FIU. And previously, I was a System Chief Operating Officer at Central Florida Health in Central Florida. Prior to that, I've held progressive positions in the C-suite for the last 19 years, ranging from Chief Nursing Officer to Chief Executive Officer. I have a doctorate degree in health administration from Central Michigan, MBA and MHA from Texas Women's University, and a Bachelor's of Science from Baylor University. Have volunteered excessively on hospital association boards and community boards, but more importantly, love teaching, love sharing the experience that we've gained over the years as healthcare professionals, and excited to be here and share our knowledge with you of what we learned through our experiences in the past 2.5 years of the pandemic. Back to you, Nancy.
Thank you, Saad, and thank you all. Thank you for the kind introductions. And we are thrilled to be here with so many esteemed participants. Just looking at the roster of participants, we are honored to be presenting our thoughts in this webinar, but also as importantly to hear yours. And we want to certainly thank our colleagues at AHA for putting this together, for the wonderful work that they do day in and day out. This is a beautiful industry that we all love and enjoy, with many challenges and opportunities that we'll talk about some today. So thanks to everyone. I'm going to serve as the moderator today with my esteemed panelists here and all the esteemed audience. So just to go over 3 learning objectives that our team put together, you all have the deck and you see the slides. We want to outline telehealth's role in organizational change, which is huge, and different care delivery models, health equity, so critical, and of course, reimbursement post-COVID-19. We strive to assess the benefits of designing technologies that are specific and help enable our physicians and other allied healthcare professionals to deliver the same outstanding care that they provide in face-to-face healthcare delivery. And finally, and I know this is near and dear to all of us, to define strategies that incorporate telehealth into those very important workflows, improving processes, looking at our patient satisfaction and turning it into patient delight, as well as our ultimate goal, which is quality of care. So with that, I'm going to turn it over to my colleague, Chris, that's going to talk a little bit about our university.
Thank you, Nancy, and thank you to everyone, both at the AHA and FIU, that worked, diligently for the last 3 months to help make this a reality. So, as having graduated both undergrad and graduate school, and from the FIU College of Law, and now, giving back to my alma mater as a professor the last 5 years, I'm happy to talk about, FIU, Florida International University, is a research public university. We have this academic year 57,000 students, which I believe makes us the 5th largest university in the country by enrollment, an annual budget of $1.4 billion, approaching close to 250,000 total alumni, both with bachelor's, master's, and doctoral degree programs throughout 11 different colleges and schools. And something, I'm very proud of, FIU is #1 in the nation in awarding bachelor's and master's degrees to different Hispanic and overall minority students. And I don't know if we're #1, but we're definitely top 5 for first generation graduates of a university, at the family level. So, shows just a great commitment for both diversity, inclusion, and also, access to higher education for our South Florida community. So I'm privileged to represent both university and also, as you can see from my badge, I work for the Public Health Trust, the public health system of Miami-Dade County here at Jackson Health System. So that I'll turn it over to Saad. We'll talk about attendee background for today.
A little bit about you all as attendees. So we broke it down into the different categories stratified by C-suite. About 4% of you represent C-suite, chief nursing officer, financial officer, and chief executive officer or president equivalent. Staff, 26% represent those of you on this call. are in that category, manager and above, at some type of management responsibilities, 25%. At a director level, we have 22%. In other category, which is a large category, 23%. 56% of you have some type of clinical degree, physician assistant, advanced practice provider, registered nurse. 18% are non-clinical, 14% other, 4% physicians, and we have 8% radiology lab, pharmacists, dentists, and other ancillary departments represented. So welcome everybody, a very diverse group. Look forward to learning from you as much as we are going to share some of our insights. Back to you, Nancy.
Hey, thank you, Saad, and thank you. What a group. I mean, I feel so energized to be part of this discussion with all of you. So we've put together about 5 discussion questions that are reflection questions that I'm going to toss out to my panelist colleagues today. And we urge you all to reflect and answer along. And I know that my colleague Jen from AHA is monitoring the chat comments and the question and answers. And we will get to as many questions and answers as we can as we go and at the end. And so the first question that we're going to put out there is, how has the pandemic impacted the relationship between the telehealth industry and the healthcare organizations? So a thought that I had when we were putting these together was, everything changed in March of 2020, a little before, a little after, but we all remember what we were doing and what our role was and how we felt about our patients, about each other, our families. And, this whole virtuality concept became so huge in our industry. So we want to ask the panelists to talk a little bit about that synergy between the telehealth industry and healthcare. If you think about it, a lot of industries came into this virtual state, some more than others, and really flourished. And one of them that comes to mind is the exercise industry, certainly not as critical as what we do, but very important to a lot of people that could no longer go to the gym or could no longer even take a walk because of elevators in their buildings. So virtual exercise and meetings, how do we all stay connected through that time? So let's talk a little bit, Chris and Saad, about the telehealth industry and healthcare organizations as it relates to the pandemic.
Thank you, Nancy. I'll go ahead and get us going on the conversation. In order to kind of talk about this, I think I want to go back a little bit prior to the pandemic and some of the challenges we saw in e-health applications and adoption to telehealth. Well, there were some challenges. Why did we, as a healthcare system, not accelerate the use of tele or virtual health services? And I think there's a 3 things that come to mind that may have been instrumental in most, if not all, markets. One was privacy and confidentiality issues. How could we prevent the individual patient networks to be compliant with HIPAA? And Chris deals with that. We also had challenges. The big one was reimbursement. There was not payer parity without the limitations of current approaches under the waiver. And we'll talk a little bit about the waiver. There was not much reimbursement, so there was not much motivation to invest in that. Couple of health systems did invest in that, knowing that it was the right thing to do. We even talked about it in different institutes in Charlotte that, look, it doesn't make sense for our patients to drive all the way from outlying areas to Center City and Charlotte uptown. And well, we can do video visits. So we were approaching insurance companies to figure out CPT codes where we could do televisit at a lower cost instead of a cancer patient coming in person and being reimbursed at the highest E&M code level. And then accessibility, right? Accessibility was an issue from a standpoint of virtual reality, from networks, people not having Wi-Fi access or other internet access. And then adoption, provider adoption was a challenge. And then also the consumer adoption was a challenge too. People like face-to-face visit, and the asynchronous visits were not really, people did not value those. So I think those were some of the challenges pre-pandemic. So as we kind of went into the pandemic, all of a sudden, consumers didn't feel comfortable coming to the clinics. They did not, for the fear of being exposed to COVID, coronavirus COVID. So all of a sudden, a lot of health systems invested in technology and telehealth services and established a platform to accelerate that. So what I would say in the last 2 years, what the pandemic actually did in the first year of the pandemic in 2020 was accelerated the use of virtual care by 5 to 6 years than we would have had we would not had the pandemic happen. So if we want to think about every, dark cloud as a silver lining, there was a silver lining. The adoption happened. The barriers went down from the provider standpoint, and the barriers went down from the consumer standpoint. And the biggest thing was that we had the waiver come in and there was payer parity where we were getting reimbursed at the same level as we would. It would be a face-to-face visit. So I think those were some of the things that kind of went into being as we looked at the pandemic impact on the market forces of behavioral change and consumer change on the providers and the patients alike.
Yeah. So
Thank you. And you go ahead, Chris. I was going to piggyback on something about privacy, which is a lot of what you do in your role. So maybe to expand a little bit on that. You covered so many great things, Saad.
Sure. Yeah, thanks, Stacey. So, I mean, Saad is absolutely correct. There was a lot of, the question was, who were going to be the initial adopters, right? The early adopters who were going to, kind of get ahead of the curve. Conference I attended from 2016 to 2019. There was always a presentation on telehealth. Everybody was talking about it. But it was a lot of talk and not so much implementation. I think to your point, Nancy, there were privacy and security concerns, making sure that we had the appropriate kind of, framework in terms of data integrity and making sure that, there was that confidentiality and privacy component that was kind of locked down. And it's really harder to monitor that, from a telehealth virtual aspect, right? Whereas on site and you're, in a facility, you have, literally walls, that can, aid in that privacy and that infrastructure, and you have designated meeting spaces and areas where clinicians can, privately and, discuss important health characteristics or health discussions and drive those discussions, confidentially and in confidence with their patients. I definitely agree that, March 2020 was the tipping point in terms of, really widespread adoption of telehealth. As Saad mentioned, a lot of adoption prior to 2020 was involving rural communities and places where, access to care was a serious problem in terms of having to drive, multiple hours and maybe potentially hundreds of miles to see your local physician, especially in areas such as behavioral health. So, and I'm a numbers person, so I'd like to share some of the numbers in terms of the staggering change, that happened, post, from pre-March 2020 to post-March 2020. So, before the public health emergency, on a weekly basis, it was approximately 13,000 beneficiaries in fee-for-service Medicare that were receiving telemedicine per week. The top of the iceberg, so to speak, was the last week of April 2020, and that month it jumped from 13,000 beneficiaries average in January to 1.7 million beneficiaries receiving telehealth services. So about a 75x plus increase in terms of telehealth in the entire month of April 2020. Nearly half, about 43.5% or 1.28 million patients received their primary care visit via telemedicine, compared to just 0.1% 3 months prior. So a huge jump. And I think, we all kind of remember that time period, right? The 15 days to slow the spread and stay home, save lives, and kind of all the uncertainty really that kind of led to that first 3 months where we were just kind of figuring out what this pandemic was really going to be. One thing I vividly remember is people wearing gloves to pump gas, right? No one wanted to touch, the thing when they're pumping gas. But, the global telemedicine market, back in 2016, to provide some context, was $24.9 billion. It is predicted to be $113 billion in 2025. So a huge jump in terms of the growth of the overall market. To provide some context, country that, unfortunately we've been talking a lot about in the world is Ukraine. Their entire GDP for their entire country is $150 billion. And McKinsey & Company has a consulting firm has recently estimated that up to $250 billion of US healthcare spend could potentially be shifted either virtual or virtually enabled care. So a huge, growth in the industry. I think, one thing that's really led to adoption is investment. So, venture capital firms like Sequoia, Andreessen Horowitz, companies that 15, 20 years ago were investing in Facebook, Google, Yammer, Stripe, these kind of tech platforms. There's been a 3x growth in venture digital investment towards the telehealth landscape. So I definitely do agree with Saad that this is kind of the future. And now, as we'll talk about, the telehealth reimbursement, support is there to justify kind of these business models.
So what comprehensive sharing you both did on your personal experiences, and you really covered, both of you, I feel like the prior, the during, the current, and the future with some great statistics, some that I didn't know of that were significant. And so Jen, is there anything that you want to chime in with from the audience, or any of you that in the chat that for this question before I move on? Or we can take those at the end.
Yeah, Lori's comment in the
Yeah.
chat was nice. She mentioned that the pandemic gave opportunity for expanded access to other providers such as registered dietitians and genetic counselors who were not previously allowed to perform telehealth visits. So I thought that was a good thing to know.
Excellent feedback. Thank you for that. So we will go to the next. Okay, question 2. Not advancing here. Let's see. For some reason, you all still see the screen because it's not advancing.
I do. Sometimes if you go down to the lower left, that will help move things along. Do you see a little arrow that will pop up? There you go.
There we go.
Oh, question 2. So we'll again invite those good reflections from the team out there. And so during the pandemic, which healthcare initiatives contributed to the growth of telehealth industry? And then the second part goes into a little bit of how traditional healthcare organizations benefited from some of these policies that are on our screen. So I'll toss that out to Saad or to Chris for some feedback on these issues.
I'm happy, to talk about kind of the COVID-19 waivers and the telehealth initiatives that really kind of expanded the scope, especially that first year, 2020 of the pandemic. So, for context, right, 25 to 30% of all healthcare spend in the United States is through federal payers. And a lot of these private payers really take the initiative or follow in the footsteps, so to speak, of the federal payer. So Center for Medicare and Medicaid Services. So one of the first steps CMS took in response to the COVID-19 public health emergency was really to expand the scope of Medicare telehealth to allow Medicare beneficiaries across the country, not just in rural areas, to receive telehealth services from any location, including their homes, which was huge. They expanded from about 60 allowable telehealth services up to 135 allowable services, more than doubling the number of services that beneficiaries could receive via telehealth. Examples include emergency department visits, initial nursing, facility and discharge visits, home visits, physical, occupational, and speech therapy services. CMS also ensured that healthcare providers like physicians were paid for these telehealth services, as Saad mentioned, at the same payment rate as they would receive for inpatient services, which was really a game changer in my opinion. Also, CMS allowed telehealth technology to fulfill many requirements for clinicians to see their patients face-to-face. So face-to-face requirements were relaxed to allow for telehealth opportunities, especially in settings like inpatient rehab, hospice, and home healthcare. CMS also temporarily expanded the types of healthcare providers that can offer telehealth service to broaden patient access to care. These include nurse practitioners, physician assistants, physical therapists, occupational therapists, dietary services, and speech language pathology. So really, these were huge shifts in the paradigm that really made, telehealth delivery a lot more, consumer and patient friendly. There's a study that showed the average consumer expectation is they want to be able to reach their physician in about a 20-minute drive or less. And with telehealth, it becomes 0 minutes. And for people that live in, large urban centers like Miami, where, you take, half an hour to an hour to get 3 or 4 miles across town. This really was both, a consumer satisfier and a patient satisfier in terms of the COVID-19 waivers and these new telehealth. I'll hand it over to Saad to give his operation.
Chris, you did a great job in how did the traditional healthcare organizations benefit. I think the benefit was really in the waiver 1135 emergency waiver that covered a lot of the reimbursement, which allowed parity in payments for us to invest and accelerate, not, I wouldn't say invest. For some, it was invest. It was some accelerate the use of virtual care, medical Internet of Things type devices where we, some of us have Apple Watches and it can capture your heart rate and all those type of things. Those are the medical Internet of Things. And we created avenues for data to be used and compiled through those devices into the medical record and incorporate those. It also challenged the healthcare systems to think differently because we went from a synchronous visit, which was face-to-face, to an asynchronous visit at any given time. A patient through the virtual platform or Epic, we have Epic through MyChart, can send a message to their provider, and the provider has certain time frames to respond back to that. And to that point, we were able to leverage our nurses and other clinicians to be able to respond to the providers and divide care planning for them as well. The other thing that I think the pandemic did was it really helped us look at the way we deliver care from a different paradigm. I think we needed to deliver care at the same level of quality at a lower cost. I think that's going to be the key imperative as we look into the future. If telehealth cannot deliver the care perceived at the same quality level by the consumer, it's not going to sustain its adoption. It has to meet the face-to-face quality perception from the consumers. The other thing I think we'll have to look at is that how can we lower our costs, which means if you can fill a lot of televisits we know there's no-shows in the clinics all the time, and in those hours we can fill the clinician's time with some telehealth type encounters. And that allows us to backfill the clinic with some more higher acuity patients. I think we have to just look at it from a different perspective. So I think what it has done, in my opinion, is really forced us to be more innovative in the way we deliver care, which means we have to be disruptive in the way we deliver ourselves, the way we offer care models. And not everybody wants a televisit. Some within the generation, some want face-to-face, some want a virtual, and some just want to e-message, be able to send a message to their physician through a MyChart and get a response, and they're happy with that. So I think those are some of the things that is helping the technological innovation in the telehealth industry as we move into the new normal during the post-pandemic.
Excellent reflection, and your level of experience is just phenomenal. And I like that whole concept that you mentioned about the consumer wanting lower cost, but the same outstanding quality and service. The on-demand, I believe one of you said 20 minutes is the farthest anyone would want to drive. And then when you put a call in, the predictability, even if it's not at that moment, of when you will get some sort of call back. And again, I know that I have used it in my own personal life and with my grandchildren when I've had them and had something I wanted to get an instant read on, that, knowing, being that I'm a nurse, that I didn't need to take them into an emergency room, which there's other challenges there too with when we were during the height of the pandemic. So anything else from the chat, or anything that we'd like to address now before I move on, Jen?
Yeah, there was a question that came in, whether or not you all were aware if there's been any changes to reimbursement from insurers now with telehealth, now that there's been a decline in COVID cases.
Sure. So, we're talking about a moving target, right? I think if we were having this conversation a month ago where COVID cases were really low, and it was like even I think Dr. Fauci talked about we have to learn to live with it and move on, and we're in the endemic phase of the pandemic. so to speak. So there's a lot of waivers that are going to be remaining permanent. There's some that are going to be taken away. Obviously, it depends on the landscape and how the utilization works and the feedback that both the government and the operational leadership feel they're being implemented appropriately. And I think it's still ongoing, but I think a lot of this is here to stay. I think adding a lot of these CPT codes to the physician fee schedule for the last 2 years has really kind of shown that there is going to be opportunities for reimbursement. So telehealth is not going away, but in terms of how much and at what level of scale, that's yet to be determined. But that's a great question.
Well, thank you for that. Thank you for that great question and that comprehensive answer. So moving on to question 3, and again, we definitely invite the reflection and the answers to some of these questions from the team at large. Which issues in healthcare do you believe the pandemic has exacerbated, and how can telehealth answer prior and more current concerns? And I know you've covered a lot of this as we've been going with access and accessibility with drive times and adoption. So what else would we add to this thought reflection here?
I'll go ahead and kick us off. I think the biggest thing, in my opinion, I can speak for North Carolina, and I think it may be transportable to other states. It's the disparity. It has really, the COVID-19 has really exacerbated and highlighted the health equity disparity that we have in our communities. And I'll give you examples of when we started setting up our clinic, setting up our inoculation vaccination sites. In the first week, we ran reports from ethnicity lens to see health equity lens to see which parts of our community ethnic groups were getting vaccinated, and we saw predominantly it was whites, and we realized we weren't reaching out to the community, the people of color, the Black and brown. And we made an intentional pause to partner with the congregations in other churches to stand up sites in those locations to be able to reach certain zip codes that were socioeconomically disenfranchised in our community. So what I've seen is, in my opinion, while telehealth is great, we have to look at and one of our attendees also mentioned, we need to be able to have infrastructure that allows for broadband, Wi-Fi, or phone or internet services to be available to all individuals to be able to use their phone to access healthcare. Most of us do have phones for the most part, but if you do not have the ability to have Wi-Fi, where you have social determinants of health impacting you, we need to look at it from that lens as well. So I think health equity within our communities has been one issue that has really surfaced as something that all health systems need to lean in towards and try to address and solve it. And they can't solve it alone. They're going to need partnership with public and private, and also city and governmental and local levels, to look at how we provide a geographic footprint of broadband coverage in order to proliferate the telehealth services.
Sure. And I just want to, and I appreciate, Saad's perspective from an operational standpoint. From my kind of regulatory perspective and what I teach and study, we've talked about all the great opportunities, both from the patient-centered standpoint and the consumer standpoint, and all the great things about telehealth and its widespread adoption. The issue that I see and the concern, that could hinder, widespread adoption, unfortunately, has been those kind of few bad apples that have kind of exploited, these telehealth opportunities. The emergence of telehealth fraud, waste, and abuse for the last 2 years has been, exponential. Unfortunately, in September 30th of 2020, the Department of Justice announced the largest telemedicine enforcement crackdown in U.S. history. It was $4.5 billion with 256 medical professionals being charged Certain defendant telemedicine executives were charged with allegedly paying doctors and nurse practitioners to order unnecessary durable medical equipment, unnecessary genetic and diagnostic testing, pain medications, without ever interacting with the patient, or very brief telephone-only conversations with patients they never met or seen. So really, this is kind of the concern, right? There's so much, kind of going through that water spigot. How do we make sure that everything, that's going through there is appropriate and meeting the needs of our consumers? So a huge emphasis, by the government through their National Rapid Response Strike Force of the Healthcare Fraud Unit that they've enacted through the pandemic to really target these bad actors and prevent them, for kind of ruining it for the greater majority of our population. To this date, there's been approximately $19 billion in alleged fraudulent billing through telehealth. I really, based on my research, there's so many different, mechanisms that these kind of fraudsters are using. But the four main categories that I've seen, number one, upcoding time and complexity. Sometimes they forget that there's only 24 hours a day and they're billing, for 30 hours, or, only high acuity when, sometimes maybe their patient population is a range of different acuities, because obviously the more time and the higher acuity, the higher the reimbursement levels. Misrepresenting the virtual service provided. So upcoding a telephone visit to an e-visit to get a CPT code with a higher reimbursement level. Billing for services not rendered. A lot of times the initial telehealth visit is what we call like a gateway scenario, where they have a brief telehealth visit to get your demographic information, your insurance information, all that. And then all of a sudden, all this durable medical equipment and other things that are unnecessary for that individual patient's needs are billed for. So, they get that initial legitimate telehealth visit, which they, should bill for in good faith, but then all these other incident things that, they're using to increase their revenue inappropriately. And then finally, kickbacks within the system. Under the anti-kickback statute, there's been a lot of prosecution for unnecessary genetic testing, prescription medications, DME, as I mentioned, and kickback scenarios where people are getting certain fees or certain royalties for overprescribing or over ordering these issues. So from a regulatory standpoint, I think that's the biggest issue the pandemic and telehealth has caused. But again, I think with collaboration, both from operational and regulatory, both public and private, we can hopefully mitigate this and just be able to see, all the benefits of telehealth without all this fraud, waste, and abuse.
That's a really elegant segue into question number 4, because the key to a lot of this, and we pose the question to everyone, is how in your healthcare organization could you implement some telehealth friendly policies to make it user friendly, like was said, many times over, some of the challenges and the barriers that were there. But how do we marry the technology and the day-to-day operations? And how do we make sure that there are policies, procedures, checklists, checks and balances in place to avoid any negativity around telehealth? So what are some of the things that we haven't covered, either from the audience through the chat, or what aspects of telehealth you'd like to see more interwoven?
I think in order for us to create a more telehealth friendly policy within day-to-day operations, within our four walls, I think it begins with training and engaging our physicians and advanced practice providers, right? We need to educate them, and we need to help them become more of IT troubleshooters too, because technology, things happen during that video visit. How do you troubleshoot? What are the backups you do in order to continue with that visit? Train and engage. At Novant, we created clinical and clerical team members. We created an operations playbook, created a SharePoint where people could post what they were seeing during the early stages of troubleshooting issues that we could engage them with, and how to help them navigate those. We're creating training CBLs, somewhat of a training vignettes for them. And then we also did the same thing with train and engage patients on patient-facing interactive visits and other type of platform of how they could be active participants but knowledgeable active participants for us. So I think looking at your platform of how you deliver care and making sure both your consumer and your care delivery team members know how to use that technology is important to adoption as well, and success of telehealth and telemedicine.
Sure. I agree with Saad, like, getting that that incorporated kind of your providers, your clinicians, your administrative staff properly trained on this ever evolving, technology and service line is very important. I mentioned kind of some of the concerns, right, in terms of making sure that, we're doing things in an above board, ethically and compliant manner. Training is that initial kind of first step, making sure that your entities provide, training on telemedicine services, on the various, ways to code and bill for them appropriately, making sure that, everybody's aware of the different, modalities that are offered, and doing it in the most patient-centric manner possible. Also, I think, given the expansion of telemedicine services in the recent months and in the past couple of years, there's been an intense, rapid growth, right, in this industry, right? So onboarding, the appropriate personnel. I know, every health system you talk about, there's a clinical shortage, right, and getting the right, clinicians, who are going to drive this change and lead the charge to efficient, cost-effective, but at the same time high quality patient care, for our patients is going to be a challenge. Making sure that we have the appropriate background and conflict checks, for all these new employees that we're onboarding, with these telemedicine training and knowledge. And then, from kind of a regulatory standpoint, compliance standpoint, monitoring activities that are involving telemedicine. It's harder to monitor in a remote environment, right? I mean, how do you, you want to kind of, provide this service and enhance that privacy and confidentiality that we all expect in our healthcare visits, but at the same time, ensure that, it's not seen as a big brother is watching, but at the same time, at some level, big brother is watching, and making sure that we're doing things appropriately and above board. And the one thing with telehealth, sometimes employees are less likely to ask questions or confirm the right way to do something because they don't have that in person. I can walk down the hall and get that support because it's a virtual setting. And then finally, telemedicine companies and health systems that are incorporating telemedicine should have mechanisms in place for reporting and investigating suspected non-compliant behavior. Again, it's about keeping each other accountable. And if we do those things, I think, the technology and the patient experience and the convenience in terms of getting a clinician or a provider right in front of a patient real time, as opposed to having to commute and wait. I mean, I think just great opportunities for this industry.
And see, I see a question by Jill. I want to address that. Jill asks, how much of the telehealth utilizations going forward will depend on clinician, provider versus patient versus consumer? Jill, I think it's a combo of both. To me, we've done the latest consumer surveys show that once patients try telehealth, they like it. The research has been compelling. We've seen almost 74% of telehealth users have reported high satisfaction. 76% are saying they're likely to use it in the future. And then when we looked at from the Medicare Advantage 65 and older population, 53% of them, seniors, are saying that their experience related to telehealth was favorable. So it's hard to understand why, because there's convenience factors involved, and there's also accessibility barriers have been reduced that way as well. And so I think the issue is going to be from the standpoint of does it provide enhanced safety in an environment from a consumer standpoint that it is safer to access healthcare from home through virtual care. It's also providing lower cost. And then Nancy pointed out earlier in our conversation, better patient experience, right? All those three things have to happen in order for consumer adoption to happen. And on the provider side, it's really the payer parity. That's going to be the key imperative in the adoption continuing forward. So did see your question, did want to call it out and make sure we answered it.
Thank you for that great question and for the comprehensive answer once again, and lots of focus on playbooks, training, coding and billing, and some of the words you used about holding one another accountable, because we all want a great patient quality experience. And so, and as was said at the way beginning, that this is something that really the silver lining was that it came to life in a way and blossomed in a way that hadn't happened before. So as we go down to the next question, which it isn't, there we go, let's see. Let's focus a little bit on the future. This is the last formal question, and then we'll take more questions as they come. The future outlook in respect to emerging technologies, new healthcare models, and of course, the big one of health equality and equity and getting access to everyone. And in your opinion, what does the field of healthcare look like post-pandemic? We all agree that it's changed forever on so many fronts, including the staff shortages that were discussed and the professional shortages. Thoughts on the future outlook for healthcare in respect to telehealth and the technologies, et cetera?
So, I mean, I think definitely we're never going to go back to the 2019 kind of, reality. I think, there's going to be a hybrid approach. Ultimately, telehealth will never replace the gold standard in-person care. If you look at the numbers too, it's also based, by, kind of service line or service need. We've seen a huge uptick in terms of behavioral health, psychiatric conditions, also, substance abuse disorder. Those seem to be the service lines most favorable to telehealth, either in hybrid or full telehealth incorporation. Just because, of the accessibility component and there's been studies that, so many people throughout the United States that a psychiatrist is more than 50 miles away, from where they currently are. So at the other end of the spectrum, surgery, emergency departments, maybe a slight hybrid approach. Maybe it's good to have, we have technology at our health system where, we can zoom in a consulting surgeon or something like that, but not yet to the fact that we have, people off-site, managing the Da Vinci robot, in the operating room. So, I think those service lines, generally in-person is going to be the gold standard, right? You need emergency physicians in the ED, palpitating abdomens, right? Making sure that, we're doing that, direct, patient observation and supervision, and surgery being another example. I view telehealth as an additional access point for a lot of patients, providing convenient care from their doctor and healthcare team. I'm going to see, I predict there's going to be a lot of leveraging of innovative technologies that, hopefully, in conjunction with in-person care is going to improve healthcare outcomes and reduce overall healthcare spending. Saad mentioned, the opportunities for reducing the overall healthcare spend for the average consumer. There's been a rapid explosion in telehealth visits that's really transformed the healthcare delivery system over the last couple of years. And I think going back to that 2019, kind of status quo would be kind of viewed as, turning the clock back on innovation at some level. In terms of categories that I think kind of are ripe, for, explosion really in the next, or at least continued growth within the next, 5 years. I think virtual office visits for primary care providers, near virtual office visits, or maybe a hybrid approach, on-demand virtual urgent cares, where maybe, unfortunately, one thing I think we all struggle in various health systems is making sure that our patients are seeing their primary care providers. They're not using, the emergency doctor physician as their PCP, right? And then finally, virtual home health services and tech-enabled home medication administration. I think those are really kind of niches in the healthcare market that are ripe, for telehealth, market growth in the next 5 years.
Chris did a great job in really giving you a comprehensive overview. The couple of things I would add is from the challenges that we got to work through is really inadequate technological infrastructure. A reliable technological foundation, including high-speed internet, widespread access to mobile devices, is crucial to telehealth delivery. I mentioned that earlier. There's one of the two things that are lacking in us being able to move forward into the next level is really lack of interoperability. There's lack of understanding of multiple technology platforms to seamlessly connect. most of all the EMRs, Epic, Cerner, McKesson, what name you, Allscripts, they all write their programs with a lack of interoperable definition, because that's their competitive advantage, and we need a standard structure for things to be called the same way and consistency for information to be shared across the platform. So that leads to the data sharing across technological platforms. And then health literacy, that's the other thing we need to look at, is the health literacy in the communities that we serve. In order to use this technology, we need for people to be able to understand what the technology is. And so almost like Best Buy has geek squads, healthcare systems may need to invest in squads that go in and educate their customers and their consumers who are coming in how to use the technology, how to troubleshoot it in order for us to be successful.
Some really great thought-provoking comments and questions about the future and what other. I'll just add one more from my role in the past in public health. And you mentioned health literacy and just the building on each individual, as well as the building and promoting of good health and lifelong healthy behaviors, and being able to get information out there. Many years ago, I served as a school health nurse here in Miami-Dade County back during Hurricane Andrew. So that's quite a while ago. And since then, it's come a long way. Not every school in the country has a school nurse. We know that. And that is a very costly endeavor. But telehealth, which it's been done here in Dade County, and different hospitals and have supported the schools in this. Imagine that in a school where there isn't a nurse, that someone could connect to a nurse remotely and keep children in the classroom and keep parents from having to leave work, but still keeping everyone safe. So I know there's quite a bit of that going on around the country. I haven't kept up as much with what's going on there. I would love if anyone has more information, because that's a passion of mine, and an amazing use of healthcare and technology together. So that concludes our 5 questions. We have some time left, and I appreciate your help and support, Jen, and all of you with managing some of these great questions coming from the broader group that's out there. So I'll stop there and thank everyone again and thank the panelists for such in-depth and broad rigor to this discussion. It was robust, and I learned a lot. Like I always tell my students, I learn as much from them as they learn from me, probably more. And so we love teaching at FIU. It's a wonderful university, and this organization at AHA, the team is amazing. So Jen, I'll turn it back to you.
Yeah, thank you. And thank you to the 3 of you for providing, different perspectives on this. I think it was really nice to have a beautiful flow of dialogue about this topic. So a question that came in is, can you comment on the use of, screening or monitoring devices for telehealth and their use in the future?
Judy, great question. The medical Internet of Things is really what I was referring to as wearable telehome care monitoring devices that people use. We have Tidal Care. We sell that as about $235, where it has an otoscope and has a laryngoscope, where we can look into, the pediatricians can look into the ear without the kiddo having to come to the clinic. And then we also have devices that people can wear that measure their heart rate, that can measure their blood pressure, and that gets fed into their medical record. The issue that we have to get past is the physicians, clinicians trusting that the data coming is accurate. Heart rate's a lot easier, but blood pressure, there's a lot of variation. If you don't put it the right way, the blood pressure could be artificially inflated or not, could be depressed. So I think as we work through those, we're going to see more telehome care monitoring devices being deployed as technology advances. And I see health systems using that more and more in their management of chronic care and also acute care episodes as well, that are past the acute into the post-acute phase. So look forward to seeing that in your communities coming more. And then your second part to the question was interoperability. So I think the interoperability issue is really more of a data governance question. And it falls into that everybody codes certain things a certain way and not differently in order for us to exchange information across the continuum. So for example, if a patient goes from one health system to the other, we gotta make sure that the data coming from one health system is coded in the same way that health system codes it, but that's not the case in the United States at this point. So as we work through interoperability issues and data governance and structure, that's more at a governmental level than it is at a local level where the tele visits are impacted. That was my comment. It's really the sharing of data and data mining, which leads to artificial intelligence and predictive medicine is when we use the data to make informed decisions.
Yeah, that was a great synopsis, and I appreciate Saad's perspective. I agree with the emergence of use of mobile devices and tracking is really going to grow. There's a famous saying in healthcare: an ounce of prevention versus a pound of cure, right? So we want to kind of monitor heart rates and these kind of important vital signs for the early kind of onset or warning signs, so we can get people to the appropriate level of care and prevent these ICU or high acuity admissions on a prospective basis.
Thanks. I'm going to end on this last question, just getting your final thoughts. So from, a bigger perspective, what is your advice or your lessons learned that you would give to organizations who are just starting their telehealth journey or are going through growing pains, especially when it comes to culture and acceptance amongst, providers and clinicians in the healthcare team?
So I think, some perspective is needed, right? I mean, at the beginning of the pandemic, it was so much, right? I like to tell my students, right, for some people, right, who were afraid, Nancy mentioned people that were afraid to come to the ED and all the exposures that were potential, right? For some people, it was telehealth care or no health care. And that was really their only two options. So, I think, the future is bright. I think, obviously, hopefully, this increase in numbers recently is not a long-term indicator. But, I'm very optimistic for the future of telehealth. I think there are going to be, like anything in life, there's going to have to be appropriate guardrails in place. And we're going to need great collaboration from both administrative, regulatory, and, on-site, clinicians in embracing this technology. But I look at it as an overall tool in the toolbox, for our overall healthcare industry. And hopefully, we can use that tool, to the best of our ability for the needs of our patients.
And great question. I would say some advice is invite your team members who have concerns and fears to come talk and lay out their fears and concerns, and then use that as a roadmap to develop your process and have them be part of the team that's developing the process, because including them in developing the new normal future of how healthcare is going to be delivered, because telehealthcare is not going anywhere. It's here to stay. So ignoring it is not going to help alleviate the stressors. It's only going to exacerbate. So I welcomed our team to talk about what their issues and concerns are, how that's going to be disruptive to their workflows, and how could they reimagine their existing workflows in the new normal, and how they could accommodate asynchronous visits versus scheduled synchronous visits. So I think that would be one. I would also recommend that y'all develop a data governance structure of how data is going to be used, what type of visits constitute televisits versus in-person visits. So those would be the three things I would recommend.
Thank you. Appreciate that. And I just want to thank Chris, Saad, and Nancy once more for a really great discussion today. And thank you to FIU in general for sponsoring today's webinar. For those that joined us, this is being recorded. So if you, we will post this on our website and share it with you all, or notify you once it's up. So if you want to share with your colleagues or revisit any parts of this, you're more than welcome to. And so when we end today's webinar, again, a reminder, there'll be an evaluation that will appear on your browser automatically. So we really value your feedback. So again, on behalf of the American Hospital Association, I want to thank everyone for joining us today, and have a great rest of your day.
Thank you. Have a great day.